Hey, so what's up, guys? Welcome back to another session of this lecture series. Now, for today, the session is going to be about antiemetic drugs, and it's a case-based learning session. So, let's see what's in there. So, something about vomiting physiology. This is a good figure which I got from the internet, but it is quite helpful because it shows a lot of, I should say, uh, mediators which help to induce vomiting. So what you can see is that you have the periphery here, and the periphery for the vomiting signals come from the ear, from the pharynx, as well as from the stomach and the small intestine. It also to extent comes from bloodborne toxins or any kind of infections. Now these all sensory inputs will eventually try to target the CTZ or the chemoreceptor trigger zone, and which in turn will try to activate the vomiting center, and then the vomiting event will occur due to relaxation of the sphincters as well as retrograde peristalsis of the upper GIT. So that's what is all about vomiting. Now what is important from our side to know is that the neurotransmitters which are involved in vomiting are mostly acetylcholine, histamine to extent, dopamine, as well as serotonin. Now, concerned with serotonin, it's mostly the intestine where and the stomach where they are located in. But if we talk in terms of any problems with the ear and so on, we talk in terms of muscarinic receptors or acetylcholine and histamine to a larger extent. Now, you should also note that vomiting can be induced if a person sees something which is not right or smells something which is obnoxious, and in that case the signals come from the hair centers. So those also can be modified by a use of certain drugs which relate themselves to cannabinoids. So that's also one thing that one needs to know about vomiting. Now, if that was a very short brief on physiology of vomiting, the next in the line are few cases which will align ourselves to the drugs used in cases of vomiting. So here is a 10-year-old boy who accompanies his family for a holiday to a beach resort. As a part of promotion on water games, Beach Resort offers them a free island hopping tour by speedboat. Now, many of you who have traveled by speedboat, you all know that it's going to be a rough ride. Not always rough, but then it moves to extent, rolls here and there on the sideways. What's it called as rolling and pitching, whatever it might be. So the classical terms for ships, rolling and pitching. So there is a lot of movement associated. So as a part of precaution against vomiting, that's also called as seasickness in layman terms, or motion sickness, and nausea, his mother applies a scopolamine skin patch behind his left ear before the journey. Now usually this drug should be applied at least 30 minutes before the journey, or need to be taken before at least 30 minutes before the journey. Don't try to take these drugs once the episode starts because the effectiveness will go down. So that was scopolamine. So what is scopolamine? Scopolamine is an anticholinergic drug. So here we come with anticholinergic drugs in cases of motion sickness associated vomiting. So what they do, as the name says, they are anticholinergic drugs, or they block the muscarinic receptors in afferent pathways of vomiting reflex. Now where did we see this acetylcholine receptors? Mostly when the signals were coming up from the ears and so on. So that's the part which is inhibited by these drugs. But anyway, they have very short duration of action. They're usually well tolerated and safe drugs. But since they are anticholinergic drugs, they will try to block cholinergic nervous system if you try to take it orally or by injectable route. So sedation, blurring of vision, dryness of mouth, urinary problems, especially if we talk in terms of elderly males with enlarged prostates and so on, then it can be an issue. Otherwise, they are all safe drugs. The dose would be around 0.2 to 0.5 milligrams either orally or by intramuscular route. Scopolamine transdermal patch. Now, since they act only for a short time, so it's best to apply a transdermal patch, and that's what is going on. So it's usually applied behind ears, any ear you can take in. Now why behind the pinna or why behind the ear is that, the problem is with the ears maintaining the position and then associated vomiting. So that's the input signal, that's where it's coming from. So you apply a drug patch nearer to the organ which is having a problem, more drug will reach the organ, less side effects, and quick will be the action. So usually this patch will be having around 1.5 milligrams of the drug, and usually the action will last for around 3 days, so need not change it again and again. So but anyway, apply it at least 30 minutes before the journey. There's one more anticholinergic drug which is not used for motion sickness, but we can use it for morning sickness. It's slightly different. Motion, morning, though it starts with there's a difference. Morning sickness relates to vomiting, which is associated with pregnancy, especially first trimester. So anticholinergic drugs are also used to extend even in morning sickness. Of course, dicyclomine is not a drug of choice for motion sickness, but it is alternative. It's not used on a daily basis, but can be used in morning sickness. So that is something about anticholinergic drugs and a case which relates to use of these drugs in therapeutics. Case 2 is about a 45-year-old otherwise healthy woman who suffers from dizziness and episodes of vomiting for 1 day duration. So there's dizziness, episodes of vomiting. She was examined and was investigated for possible abnormalities in ear, CVS, GIT, and CNS. So she's 45-year-old, she has dizziness, she has vomiting, so it can be problems mostly concerning with her ears either, or rarely I should say, since this is just one episode, but don't know, you need to examine at least the patient for all the possible abnormalities. So try to check her GIT, CVS, because that's also one more system that can relate to dizziness, and CNS of course, because that also relates to dizziness and vomiting. So need to check these systems before you come to a specific diagnosis. Though to me she might be just a case of vertigo, being a female who is middle-aged and so on. So she was diagnosed to have vertigo with nausea and vomiting. So mostly middle ear problem, that is what she is having. Anyway, whatever she is having, she was prescribed injection Prochlorperazine. It's a phenothiazine drug. It's also a drug, antipsychotic drugs that we call as. So I'll come to these drugs. So she was prescribed injection Prochlorperazine, and she was also prescribed tablet Cinnarizine for maintenance for around 7 days. So for the acute incidence, that was Prochlorperazine, and for Cinnarizine was for maintenance phase. And other antihistaminics can also be used for nausea and vomiting due to other causes. So yes, antihistaminics, we also have seen that in the physiology. So histamine plays an important role in afferent relay signals. So antihistaminics can be used even in motion sickness, not a drug of choice, but if you don't have scopolamine, you can use a what I call as antihistaminic drugs. So you can also use it for some other causes of nausea and vomiting, mostly relating to ear problems and so on. So you can use antihistaminic. She felt better after treatment, but what was a bit drowsy. Now that's important. She was given this drug, but she is okay, but is drowsy. She was advised not to drive during her treatment. Now that's also an important part. Note these two lines at the end. People are going to feel drowsy once they take these drugs, especially antihistaminics, because they bring about a lot of sedation, and especially when they want to drive, or if that was a male person, not something related to male, but anyway, if they are working with heavy metals, objects, lifting weights and so on. So I'm not talking of gym weights, I'm talking of machinery, heavy machinery and so on. So people who are into this field need to be careful because they might be drowsy. So at times, especially working with heavy machineries and so on, so that can bring about an accident and so on. So try to avoid driving and working with heavy machineries, especially precise one and so on. Try to be very careful, especially once these drugs are given, especially antihistaminics. So then the question comes, she was given phenothiazine drug, that is what we call a prochlorperazine. So what is that? It's a non-selective dopamine antagonist. Now we have seen that dopamine plays an important role in the relay mechanism, especially centrally. If we talk of afferent impulses that bring about vomiting. So phenothiazine group of drugs, are also called as antipsychotic drugs, are non-selective dopamine antagonists. So they will block the dopamine and the central in the CNS. So central dopamine receptor antagonists. They are potent and high efficacy antiemetics, and that's why she had that dizziness attack, vomiting. So if you want to treat a person in an acute state, somebody has a fall, a vertigo, a dizziness incidents happening in your clinics, now you want to give some drugs which can bring them back to at least 90% to normality, then you should be using these drugs. So prochlorperazine, it's available as tablets, 5 to 10 milligrams, or vials, which we use mostly as injectable preparations, can be given. 2 ml, 5 ml are available as per what is required. You need to give it to the individuals. Controlled release capsules, so that they can keep on releasing and the person can get the effect. Suppositories, because people are vomiting. So in those cases, if you want acute action to come in and you don't want to go for injectable preparation, suppositories of this drug prochlorperazine is also available. Just push one suppository in the anal canal and that should be okay. Syrups are also available, but try to avoid these drugs in children less than 2 years of age. They are not to be used because they can bring about a lot of problems to the individuals. We have one more drug in this category, which is called droperidol. It's the same as prochlorperazine. It's a central dopamine receptor antagonist, non-selective one. But the problem with droperidol is that you need to monitor the ECG because it can bring about QT prolongation and other cardiac toxicities can come in. You want to use that, then you can use it as 2.5 milligrams IV or IM slow injections. You can add 1.25 milligrams if needed, but try to give at least a gap of 2 to 3 hours before you want to give the another dose. Children, as I said, better to avoid, but if you want to give it, then a dose would be 0.1 milligrams per kg, but with caution. Now these drugs are potent drugs, as I said to you, so try to limit their use for moderate to severe cases, especially acute episodes. Don't try to use it for normal cases of vomiting. Vomiting related to ear problems, you can use these drugs. Post-operative vomiting, people get vomiting episodes after they are operated. Reasons might be anesthetic drugs bring about relaxation. They are not in the same time frame person as what we are for a long period of time. Bedridden individuals, they do not eat, so and it's a stress factor. So a lot of these things can bring about vomiting. So post-operative vomiting is very common. The reason we want to avoid this, rather I should say, is that aspiration pneumonia can occur. You do not want post-operative patients to vomit because they are slightly dizzy, so some vomiting contents might enter into the respiratory tract and can give rise to pneumonia or any kind of other infections. So try to avoid. So prophylactically you can give these drugs in post-operative vomiting, though we have better drugs available. As far as these are not the only drugs available, we can also use these drugs for chemotherapy, cancer chemotherapy associated of vomiting. Better drugs are available. So as I said, the most likely incidence where you want to use these drugs is acute episodes of vomiting, where you want to use that drug. But mostly for post-operative vomiting or cancer chemotherapy vomiting, we have specific safe drugs available, because the side effect profile of these drugs is on a higher side. So extrapyramidal side effects, which is mostly dystonias and dyskinesias that occur. So they block the dopamine receptors in the CNS, so that can give rise to this extrapyramidal effects. Now they might be very easy to treat, and you might see them often in your clinical practice, but the thing is that if that happens to a patient, the patient takes it very seriously, because this dystonias, dyskinesias, especially torticollis, abnormal movements of the lips, tongues, eyes, and so on, it can be a problem. It can be very distressing for the individual. So better to avoid these drugs, as I said. Only use them whenever required, acute incidences in mild to severe cases. Now, how you want to treat these episodes of extrapyramidal side effects? You need to just reassure the patient. Okay, after reassurance, maybe it comes down. Sedatives, and in severe cases you can provide L-Dopa. L-Dopa is a prodrug that is transformed to dopamine. So you block dopamine by using these drugs. So if side effect comes, give dopamine, not in a direct way, but by giving L-Dopa. So L-Dopa gets converted, or levodopa gets converted to dopamine, and tries to bring down the side effect profile of this drug, especially extrapyramidal side effects. So that was about phenothiazines, especially prochlorperazine. That's important because we use it. I think the brand name Stemetil. That is what it is. Antihistaminic drugs, yes, the next class of drugs, because we used in that case of a female with vertigo even Cinnarizine. So that was an antihistaminic drug. So CNS inhibition of histaminic pathways, which controls vomiting in cases of vertigo, motion sickness, and post-op. Very clear. Histamine is responsible for the relay of afferent impulses. So block it. So we use antihistaminic drugs. Promethazine thioclate is one of the important antihistaminic drugs. Try to avoid it in children. Dimenhydrinate is one more antihistaminic. Meclizine, it's a long-acting one, will act for around 24 hours with a dose of around 12.5 milligrams. Cyclizine is one more antihistaminic drugs with 50 milligram dosage that can be given to the individual. Very specific would be Cinnarizine. It's an anti-vertigo drug, slightly different from the other drugs, antihistaminics. It's an antihistaminic but with additional action on the ears, so it will increase blood flow to the vestibular nucleus and will inhibit calcium entry into vestibular sensory cells. So very important drug, slightly different in action, though antihistaminic, but very specific for vertigo associated with ear problems, because there's something that really leads to related to ear problems. So that's the reason. Sedation is a major side effect, so don't want to use heavy machinery if you are using these drugs. Do you want to use these drugs for morning sickness? Claims say that they can be teratogenic in nature, though there is no hardcore evidence, but then it is best to avoid these drugs, especially for morning sickness. But for motion sickness, vertigo related to ear problems, post-op patients, very good drugs. Cinnarizine, mostly for ear problems and vertigo associated with tablet 25 and 75 milligrams PD. Promethazine, it's available as tablet and injections, 6.25 milligrams, 12.5, 25 milligrams, 4 to 6 hourly. Injections also used to reduce extrapyramidal effects due to phenothiazine. So that's important. You want to use any sedative, you want to use antihistaminics also like promethazine. And the thioclate is one salt that is more of use in vertigo cases or vomiting cases, I should say. So that's about antihistaminic drugs. Case 3 is a 75-year-old man who suffers from, 25-year-old man who suffers from gastroenteritis and has vomiting and diarrhea. Very common to see, right? He was prescribed tablet domperidone 10 milligrams BD for vomiting. His vomiting stopped after treatment. He was advised to continue treatment for another 2 days. So one more drug in addition for adult with gastroenteritis with vomiting and diarrhea. Case number 2 is a 25-year-old female. She is pregnant. She suffers from episodes of nausea and vomiting. That's called as morning sickness. She asked for advice, and usually what we give for this patient is reassurance, because that's the most important. But if at all you want to use any drug, then tablet pyridoxine, 200 milligrams per day. Mechanism of action is not clear of how the action takes place, But usually what we see is that pregnancy is associated with deficiency of pyridoxine. So deficiency of pyridoxine leads to imbalance in the GABA. GABA is a neurotransmitter that's kind of inhibitory neurotransmitter within the CNS. So any disturbances in the levels of GABA will give rise to excitability of the CNS, giving rise to vomiting. So that's why we want to use pyridoxine. But you see the dose here, it's quite high that we give. But anyway, we don't know exactly what's the reason, but as what is said in the textbooks is all related to the imbalance of the GABA neurotransmitter within the brain. If at all the patient has hyperemesis during pregnancy, then you can use metoclopramide 10 milligram, injectable preparations of metoclopramide, one more additional drug. So we have seen domperidone. The next drug is metoclopramide. Of course, for this case, pyridoxine reassurance is the best way. Her condition improved after taking medication, and in general as her pregnancy continues, because vomiting or morning sickness is mostly related to first trimester. As the pregnancy continues, these all things get down on their own. A few countries will be using antihistaminic tablets like doxylamine and so on. But anyway, as I said to you, these drugs can be of teratogenic potential. So few countries ban them, but in few countries they are used. So it's up to you whether you want to use an antihistaminic or not. If at all you want to use, the best antihistaminic would be doxylamine, that you want to use it in pregnancy along with pyridoxine. But if there is hyperemesis, vomiting that is more than what the patient can have, then of course metoclopramide or any other antiemetic drug can be of choice, especially ondansetron or granisetron. Okay, so that was about pregnancy and vomiting. Case number 5 is about a 20-year-old man who underwent surgery for repair of inguinal hernia under GA. So he has underwent operation under general anesthesia, that is GA. He was given injection metoclopramide for prevention of vomiting and aspiration after surgery. That's where it stands to. So injection metoclopramide, again we are coming back to this drug. He suffered from torticollis after injection, which was treated immediately. That relates to abnormal movements of the neck, which is a kind of extrapyramidal side effect. So he was given maybe some other drug. We have seen that we can give a sedative, reassurance, antihistaminic drugs, promethazine and so on to bring it down. Injection metoclopramide is available as 5 milligrams per ml. Depending upon what the dose is, you need to give the injection to this patient. Especially post-op, we try to give injectable preparations rather than giving any oral preparations for this individual. So once we have seen these 3 cases, now relate them to drugs that we have seen. The first drug that we will come across is dopamine or D2 antagonist. We have that non-selective antagonist like phenothiazines, having overall action on the dopamine relay signals, input signals, but with lot of extrapyramidal side effects. Now here are selective dopamine antagonist drugs, D2 receptor antagonist drugs. So they will block the D2 receptors in the CTZ, chemoreceptor trigger zone. So the first drug of this kind is metoclopramide. We have seen this drug. It's of short duration of action. Action will last for around 6 hours, so needs to be given at least thrice daily. Domperidone is given twice daily, one more drug that we have seen. So it's alternative. You can use metoclopramide or domperidone. Both these drugs are prokinetic. Now remember, they are also prokinetic. They are just not blocking the dopamine, but they are also prokinetic in nature due to their serotonin agonist activity. So they are agonist activity, so they will try to hasten the process of food being entering the small intestine from the stomach and so on. So try to prevent vomiting even in those cases. At high doses, they inhibit 5-HT3 receptors also. Okay, so they are mostly on dopamine side they are antagonizing, but if you look at the serotonin side, they are prokinetic in nature. Domperidone is available only as oral preparation. So syrups, tablets of domperidone, mostly used for vomiting on a wider scale nowadays. or we have metoclopramide, which is mostly of oral use and IV use. But there is a difference, though these drugs are of the same class and you can use them as one drug alternative to the other one. See, remember, metoclopramide crosses the blood-brain barrier, but domperidone cannot. So that's important. So domperidone see, they are blocking dopamine. So again, extrapyramidal effects will be coming up. So metoclopramide will cause more extrapyramidal side effects like torticollis and so on that the case had described. But as far as domperidone is concerned, maybe less of these side effects. So well tolerated, safe drug, I should say, at all ages. One of the best drugs for vomiting. So that's the difference between metoclopramide and domperidone. So my preference would be, my P drug would be more of domperidone. But then again, there will be cases where I need to use an injectable preparation. I might go for metoclopramide, because that's the only drug with injectable preparation in this group. Injection promethazine, a sedative, I already informed you, can be given for extrapyramidal effects. Domperidone is well tolerated. So all types of mild to moderate vomiting, as I said to you, domperidone is kind of a universal antiemetic drug nowadays. So for all kinds of mild to moderate vomiting, you can use domperidone as a drug of choice, except for kind of chemotherapy associated vomiting and so on. But it's very specific and of high grade, you won't be using these drugs. Otherwise, good drugs as far as antiemetics are concerned, action is concerned. Case number 6 is a 1-year-old boy who suffers from episodes of vomiting and diarrhea for the last 12 hours. He shows no signs of dehydration and is active. So he has vomiting and diarrhea, and he is 1-year-old boy. He was prescribed oral rehydration salt, and you all must be knowing it's a condition which mostly relates to a lot of hospital admissions in the pediatric age group. So that relates to viral gastroenteritis, rotavirus, diarrhea, and so on. So not to go into those details. So mother complained of more episodes of vomiting after he was started with ORS. Children tend to throw out ORS because they don't know, parents don't know how to feed children with ORS. There's a technique. It's not that just you keep and give it spoon by spoon. It's not like that. There's some technique which needs to be applied so that children don't get vomiting. Otherwise, it's not something which is great to taste. Anyway, we have a lot of flavors available nowadays with ORS. But then again, there is a lot of issue with this vomiting. That is not directly related to the side effect of ORS, but children are usually sick. They have diarrhea and vomiting. So in that, you try to feed them, they just vomit. Anyway, so GP insists on continuing ORS. You need to give ORS to the individual. It's not something which you can cut it off. Breastfeeding was continued throughout the course of illness. It's widely known that you need to continue breastfeeding. It's not that you can just stop it. The boy was given syrup Ondansetron for vomiting, one more drug in the list. ORS and other supportive medications were continued. And you need to avoid all anti-diarrhea drugs in all cases of any kind of infective or viral gastroenteritis. Do not give diphenoxylate, and so especially it's just 1 year. But anyway, in any other cases infective origin, try to avoid any anti-diarrheal drugs, especially opioid substitutes. In the next 4 hours, his vomiting stopped. So he was given an antiemetic drug. You can of course give antiemetic. There's a lot of school of thoughts regarding that also. But anyway, whatever I've seen nowadays and reports come about is that they are better to be given, so that you try to avoid hospitalization, less vomiting, less suffering, and so on. So syrup Ondansetron is nowadays given for vomiting, but no to any anti-diarrheal drugs, especially opioid substitutes. That's one of the primary rules of treating any kind of gastroenteritis. The next case number 7, is about a 67-year-old smoker who was diagnosed to have lung carcinoma. He was prescribed a chemotherapy for that. He was given injection Ondansetron 8 milligrams IV, and then was repeated till maximum of 32 milligrams in a day. Supportive therapy in the form of injection dexamethasone and IV fluids were also given. So you need to support chemotherapy associated vomiting with steroids, IV fluids, and so on. Vomiting was controlled partially. He felt a little better, of course. Yeah. So what is this Ondansetron? It's a serotonin 5-HT3 antagonist drugs. Very important because they are also responsible for a lot of afferent impulses from the GIT, especially stomach and the intestine. So try to block these impulses, and especially these will be secreted and the impulses will be generated at times of chemotherapy or at times of radiation and so on. So try to avoid vomiting in these cases. Try to antagonize serotonin at that level. So they are highly potent and high efficacy anti-emetic drugs. Ondansetron is a prototype drug, 4 to 6 hours of action. It antagonizes 5-HT3 receptors present in the CNS and the periphery. It has high first pass metabolism and is excreted by liver and kidney. You need to be aware that in hepatic insufficiency you need to reduce the dose, otherwise for renal insufficiency it's okay. It's actually a well tolerated drug. Severe vomiting cases, now usually my P drug for most of the severe vomiting cases would be Ondansetron or a 5-HT3 antagonist. Chemotherapy induced or post-operative vomiting, you can use these drugs. For chemotherapy associated vomiting, you can use drugs like steroids, adjuvant drugs, 20 milligrams of dexamethasone or even more to extent can be used. Usually serotonin 5-HT3 antagonist drugs are well tolerated. A few side effects mostly would be either constipation or diarrhea. That's important. QT prolongation, dry mouth and headache is what I have seen with this drug. Especially headache is most common. Raised liver enzymes can be a problem and allergic reactions. Tablets of Ondansetron 4 and 8 milligrams need to be given BD. Syrups, injectable preparations are also available. 2 milligrams per ml. You need to give 8 milligrams IV to a maximum of 32 milligrams. In any case, either pre-chemotherapy or post-chemotherapy, or divide doses accordingly to avoid any vomiting associated with this chemotherapy of cancer. Granisetron, which is one more form of 5-HT3 antagonist, is a more potent anti-emetic drug with a BD dosage, twice a day dosage. Now, if that was about 5-HT3 antagonist, there are a few other drugs which are also used as adjuvant to therapies. The one which is noted here are cannabinoid drugs. Now, we also have noted in the physiology that higher centers also, you see something which is not right, or something which is not pleasant to see, or you hear something which is not good, or at times even smell something which is obnoxious at times, so you feel like vomiting. If you're seeing a car accident, you might feel like vomiting. The immediate reaction can be just vomiting and so on. So we have those higher centers which also play a role in trying to activate the vomiting center and then cause the event of vomiting. So cannabinoid receptors and the pathways are also responsible for kind of impulses which are generated from the higher centers. So try to block them. Try not to block them. Try to use these signals so that we can try to relieve the patient out of vomiting. So we have two drugs in this class, Dronabinol and Nabilon. I think Dronabinol is a tetrahydrocannabinoid, whereas Nabilon is a more synthetic product. It's available as oral formulations. Mechanism of action is not precisely known of how they bring about anti-emetic action. Anyway, they are used as adjuvant in chemotherapy induced vomiting. So we learnt about steroids. So one more drug would be cannabinoids, especially Nabilon, orally available drug. Sedatives, yes, we use benzodiazepines, lorazepam as adjuvant therapy in severe cases of vomiting. Again, they are usually the mechanism is not known of how their action, anti-emetic action takes place, but usually they will be having kind of inhibitory action onto the CNS by regulating the levels of GABA and so on. So that would be one of the reasons of why we want to use them. But anyway, just as an adjuvant, not something which is as a monotherapy or a startup therapy. It's available as injection 2 milligrams, which can be given for the individuals. So that's about a few drugs that we use for antiemetics with those cases that we have seen. One more case I want to just let you all know: vomiting is not essential at all times. That is what I just want to stress at the end of this lecture. So 25-year-old boy has a breakup and in grief, that is depression, took 20 ml of organophosphate poisons. Especially those from the developing country will always note this as a very cheaply available, and we see so many cases in the ER, especially with organophosphate poisoning. He was brought to the ER with within 1 hour with episodes of vomiting and frothing through mouth. Again, if you're new to my channel and don't know about organophosphate and its clinical implications, you need to go back and try to search for video on organophosphates on my channel, which will give a total description about this case. Again, a very important clinical scenario, especially in practice. He was given gastric lavage and no antiemetic was administered. Now, you do not want antiemetics to be given in this case. You do not want the poison to remain inside the stomach. In fact, you want the poison to come out. So we don't use antiemetics. The point I want to stress with this case is that we don't use antiemetics for all causes of vomiting. No, if it's a poison inside the stomach, better to avoid any antiemetics, especially in the first few days after he has taken the poison. His condition improved slowly with other treatments given to him. So my point is, no to antiemetics in all cases of vomiting. It might be something else, you can give it, but not in this case where he has taken the poison orally and the poison is inside his stomach. So that is all about antiemetic drugs. Thank you. I hope you like this session and do subscribe to channel. Bye.